Monitoring of the critical ill patient. In the ICU, the monitor is more than a machine, it is the voice of a patient who cannot speak. Behind every waveform, every alarm, and every number is a life hanging in the balance, waiting for us to notice, to interpret, and to act. This presentation on monitoring of the critically ill patient is about more than parameters. It is about principles that guide us, practice that saves lives, and vigilance that makes the difference between deterioration and survival. We monitor not because we have to, but because we care. We detect early because every minute matters. We collaborate because no one saves a life alone. Together, let us commit to monitor accurately, intervene early, and save lives. That is the true meaning of excellence in critical care. Clinical presentation. Monitoring of the critically ill patient. Principles, parameters and practice in the intensive care unit. Lecture notes. Nursing Clinical Sciences, Critical Care Module. Focus. 1. Core principles of ICU monitoring: accuracy, continuity and early detection. This ensures subtle deterioration is recognized before it becomes life-threatening. 2. Essential parameters: vital signs, respiratory, neurological, renal and laboratory trends. This provides a complete picture of multi-system function in the critically ill patient. 3. Clinical practice: interpretation, documentation, communication and timely intervention. This links monitoring to decision-making and patient safety at the bedside. Goal: monitor accurately, intervene early and save lives. Lecture roadmap. Learning objectives. 1. Define critical care monitoring and state its core goals. 2. Differentiate clinical, non-invasive, and invasive monitoring. 3. Describe key cardiovascular, respiratory, neurological and renal parameters monitored in the ICU. 4. Explain indications and principles of invasive monitoring devices, arterial line, CVP, PAC. 5. Discuss the clinician's role in continuous surveillance and early recognition of deterioration. 6. Identify complications associated with invasive monitoring. Introduction, definition and concept. What is monitoring? A cornerstone of safe critical care practice. Monitoring is the continuous or repeated observation and measurement of a patient's physiological parameters, using clinical skills and/or technology, to detect trends and deviations from normal in a timely manner. A critically ill patient is one with an actual or potential life-threatening failure of one or more organ systems, requiring intensive support and close surveillance. 1. Combines clinical judgment with technology-based data. This ensures accurate interpretation beyond machine values and supports sound clinical decisions. 2. Ranges from simple bedside observation to complex invasive devices. This allows monitoring to be tailored to the severity of illness and available resources. 3. Guides diagnosis, therapy, and prognosis in real time. This enables early intervention and better prediction of patient outcomes. Purpose. Goals of patient monitoring. 1. Early detection. Identify physiological deterioration before it becomes catastrophic. This allows prompt intervention before irreversible damage occurs. 2. Guide therapy. Inform diagnostic and decisions in real time. This ensures treatment is based on current patient needs rather than assumptions. 3. Evaluate response. Assess effectiveness of interventions, fluids, drugs, ventilation. This helps determine if therapy is working or needs adjustment. 4. Prevent complications, anticipate and avoid secondary organ injury. This reduces morbidity and prevents additional system failure. 5. Support prognosis. Track trends that inform outcome and care planning. This aids in realistic family counseling and resource planning. 6. Ensure safety. Provide continuous surveillance for a vulnerable patient. This protects the critically ill patient who cannot advocate for themselves. Overview. Levels of monitoring. 1. Clinical bedside. Nurse clinician observation. Lock, color, capillary refill, urine output. This provides immediate, low-cost assessment without equipment and detects early changes. 2. Non-invasive. Pulse oximetry, NIBP cuff, ECG, temperature probes. This offers continuous data with minimal risk to the patient. 3. Invasive hemodynamic arterial line, CVP, pulmonary artery catheter. This provides accurate, beat-to-beat measurements in unstable patients. 4. Laboratory and imaging. ABG, electrolytes, lactate, chest X-ray, echocardiography. This confirms bedside findings and guides definitive treatment decisions. Level 1. Clinical bedside monitoring. The simplest, cheapest, and most valuable form of monitoring, a skilled clinician at the bedside. 1. Level of consciousness, alertness, orientation, GCS. This indicates brain perfusion, early neurological change. 2. Skin color, warmth, and capillary refill time, and LT, 2 seconds. This reflects peripheral perfusion and circulatory status. 3. Work of breathing, rate, effort, use of accessory muscles. This shows respiratory distress and increased oxygen demand. 4. Urine output, reflects renal perfusion and circulating volume. This is an early indicator of kidney function and fluid balance. 5. General appearance, comfort, and pain assessment. This identifies distress, anxiety and unmet needs. 6. Frequency of observation increases with patient acuity. This ensures sicker patients receive closer surveillance and timely intervention. Bedside check. Consciousness GCS, skin color and warmth, capillary refill, breathing pattern, urine output, pain and comfort. Level 2 non-invasive. Vital signs monitoring. Normal ranges. Our heart rate 60 to 100 BPM. Indicates cardiac workload and perfusion status. RR respiratory rate 12 to 20 breaths per minute. Reflects oxygen demand and respiratory compensation. Temperature 36.5 minus 37.5 C shows metabolic state and possible infection. SpO₂, oxygen saturation, 95 minus 100%. Measures adequacy of oxygenation. BP, blood pressure, 90/60ths 120/80ths of a millimeter of mercury. Indicates circulating volume and organ perfusion. Key notes. 1. SpO₂ is often called the fifth vital sign, always assessed alongside our RR, BP and temperature. This ensures hypoxia is not missed during routine assessment. 2. In critical illness, vital signs are monitored continuously rather than intermittently. This allows immediate detection of life-threatening changes. 3. The trend over time is more clinically significant than any single reading. This helps differentiate transient changes from true deterioration. Cardiovascular monitoring. Continuous ECG monitoring. 1. Continuous 3 or 5 lead electrocardiography displayed on the bedside monitor. This provides real-time visualization of cardiac electrical activity. 2. Detects heart rate, rhythm disturbance, and SAINT segment changes suggestive of ischemia. This allows early identification of arrhythmias and myocardial injury. 3. Electrode placement and skin preparation affect signal quality. This reduces artifacts and ensures accurate tracing. 4. Individualized alarm limits reduce alarm fatigue while catching true events. This prevents desensitization to alarms and improves response to real emergencies. 5. A 12-lead ECG is obtained for detailed diagnostic evaluation. This gives a comprehensive view for definitive diagnosis. Bedside ECG trace example. Hour 88 BPM, normal sinus rhythm. Clinical tip. Sudden rhythm change is often the earliest monitor sign of clinical deterioration. This is why continuous ECG surveillance is critical in the ICU. Cardiovascular monitoring. Non-invasive blood pressure, NIBP. 1. Automated oscillometric cuff on the upper arm, measured at set intervals. This allows regular BP checks without invasive procedure. 2. Correct cuff size is essential. Wrong size gives false readings. This ensures accuracy. Small cuff overestimates and large cuff underestimates. 3. Convenient and low risk, suitable for stable patients. This makes it ideal for routine monitoring on the ward and stable ICU patients. 4. Limitations. Inaccurate during arrhythmias, shivering, or severe hypotension. This is because movement and irregular flow interfere with oscillometric detection. 5. Cannot provide beat-to-beat data, a limitation in unstable patients. This means drops in pressure may be missed between intervals. Normal adult BP, 90/60ths 120/80ths of a millimeter of mercury. Mean arterial pressure, map target in shock states, is greater than or equal to 65 millimeters of mercury. This pressure is to maintain organ perfusion. Level 3 invasive monitoring. Invasive arterial blood pressure. 1. A catheter is placed in the radial, femoral, or brachial artery. This provides direct access to arterial circulation for monitoring. 2. Provides continuous, beat-to-beat blood pressure via a pressure transducer. This gives real-time BP even in shock or arrhythmia, where NIBP fails. 3. Enables frequent arterial blood gas sampling without repeated punctures. This allows repeated ABG and blood sampling without new needle sticks. 4. Indicated for hemodynamic instability, vasoactive drug infusions, and major surgery. This is needed for safe titration of inotropes and vasopressors. 5. Requires an Allen's test before radial cannulation, and a zeroed, level transducer for accuracy. This ensures adequate collateral circulation and correct pressure readings. Why invasive art line? Beat-to-beat accuracy. Real-time BP even in shock or arrhythmia. This is crucial for rapidly changing patients. Repeated sampling. AB, bloods without new needle sticks. This reduces patient discomfort and repeated arterial puncture. Vasoactive drug titration. Safe use of inotropes, vasopressors. This allows precise adjustment based on continuous pressure. Complications. Bleeding, thrombosis, infection, distal ischemia. This requires strict asepsis and regular perfusion checks. Level 3 invasive monitoring. Central venous pressure, CVP. 1. Catheter tip sits in the superior vena cava, right atrium via a central line, internal jugular, subclavian, or femoral vein. This gives direct access to central circulation for pressurement. 2. Reflects right ventricular preload and venous return. This indicates how much blood is returning to the right side of the heart. 3. Used to guide fluid resuscitation and assess volume status. This helps decide whether the patient needs more fluids or fluid restriction. 4. Also allows central drug administration and blood sampling. This enables safe delivery of vasopressors and irritant drugs that cannot go peripherally. 5. A single value is less useful than the trend in response to a fluid challenge. This is because CVP is affected by many factors, so change over time is more meaningful. Normal CVP, 2 to 8 mmHg. Interpretation. Low CVP right pointing arrow hypovolemia. Suggests low circulating volume and need for fluid. High CVP pointing arrow fluid overload, right heart failure, tamponade, tension pneumothorax. Indicates impaired venous return or cardiac dysfunction. Level 3 invasive monitoring. Pulmonary artery catheter, Swan-Ganz. 1. A balloon-tipped catheter advanced through the right heart into a branched pulmonary artery. This allows direct measurement of pressures inside the heart and pulmonary circulation. 2. Measures pulmonary artery pressure, pulmonary capillary wedge pressure, a surrogate for left atrial pressure, and cardiac output by thermoddilution. This provides detailed hemodynamic data on preload, pulmonary pressures and pump function. 3. Reserved for complex cardiogenic shock, severe pulmonary hypertension, or undifferentiated shock. This is because its benefit is limited to complicated cases where other monitors are inconclusive. 4. Largely superseded by less invasive cardiac output monitors and echocardiography, but still used in select cases. This is due to its invasive nature and associated risks, with safer alternatives now available. Normal values. PAP, 15-30/4 - 12 mm of mercury. Reflects pressure in the pulmonary artery and right heart workload. ECWP, 6-12 mm of mercury. Estimates left atrial pressure and left ventricular preload. Cardiac output, 4 to 8 L per minute. Indicates overall heart performance and tissue perfusion. Respiratory monitoring. Pulse oximetry, SpO₂. 1. Non-invasive, continuous estimate of arterial oxygen saturation via a finger, ear, or toe probe. This provides quick oxygen status without needing a blood sample. 2. Normal range, 95–100%, individualized in chronic respiratory disease. This range ensures adequate tissue oxygenation. Lower targets may be accepted in COPD patients. 3. Provides an instant, continuous early warning signal of hypemia. This allows rapid detection of desaturation before clinical signs appear. 4. Limitations. Poor peripheral perfusion, motion artifact, nail polish, and carbon monoxide poisoning give falsely reassuring readings. This is because the sensor relies on good glow and light absorption, which can be disrupted. 5. Does not measure ventilation, CO2. A normal SpO₂ does not exclude rising CO2. This means a patient can still have hypoventilation even with normal oxygen saturation. Example reading: SpO₂ 98%, pulse 84 bpm. Keynote: SpO₂ less than 90% equals urgent action required in most patients. This level indicates significant hypoxia requiring immediate intervention. Respiratory monitoring. Capnography. End title: CO2. 1. Measures CO2 in exhaled breath. Reflects ventilation, not oxygenation. This shows how effectively CO2 is being cleared from the lungs. 2. Confirms correct endotracheal tube placement immediately after intubation. This provides immediate verification that the tube is in the airway and not in the esophagus. 3. Continuously detects hypo or hyperventilation and circuit disconnection. This allows early recognition of breathing problems or ventilator issues. 4. A sudden drop in ETCO₂ is an early sign of cardiac arrest, massive PA, or cardiac output failure. This is because ETCO₂ falls when pulmonary blood flow or circulation drops suddenly. 5. Normal ETCO₂ 35–45 mm of mercury. This range indicates adequate alveolar ventilation. Example waveform. Capnograph waveform with ETCO₂ 38 mm of mercury. Rule of thumb: SpO₂ tells you about oxygenation, ETCO tells you about ventilation. This distinction helps interpret respiratory status more completely. Respiratory and metabolic monitoring. Arterial blood gas (ABG) analysis. A single arterial sample gives a rapid snapshot of oxygenation, ventilation, and acid-base status. This helps assess gas exchange and metabolic state quickly in critically ill patients. Parameters. pH, normal range, 7.35–7.45 reflects acid-base balance. This shows whether blood is too acidic or too alkaline, indicating metabolic or respiratory disturbance. SpO₂ normal range, 80–100 mm of mercury, reflects oxygenation. This indicates how well oxygen is moving from lungs into blood. SpO₂ normal range, 35–45 mm of mercury, reflects ventilation, alveolar CO2 clearance. This shows whether the lungs are effectively removing CO2. HCO3 normal range, 22–26 mmol/L, reflects metabolic renal compensation. This indicates how kidneys are buffering acid-base changes. Lactate, normal range, less than 2 mmol/L, reflects tissue perfusion and shock marker. This rises when tissues lack oxygen, suggesting poor perfusion or shock. Respiratory support, mechanical ventilator monitoring. 1. Tidal volume, respiratory rate, and minute ventilation. This shows how much air is being delivered each minute and the basic pattern of ventilation. 2. Peak positive end expiratory pressure, and SpO₂ delivered. This indicates oxygen support and lung recruitment, helping keep alveoli open and improve oxygenation. 3. Peak and plateau airway pressures. A rising plateau pressure warns of falling lung compliance. This helps detect stiff lungs, worsened compliance, or high risk of ventilator-induced lung injury. 4. Ventilator waveforms, flow, pressure, and volume loops reveal patient ventilator asynchrony. This allows detection of fighting the ventilator, so settings can be adjusted for comfort and safety. 5. Watch for high pressure or low tidal volume alarms, which demand immediate assessment. This alerts to obstruction, disconnection, or worsening patient condition that needs urgent action. Key ventilator settings. Tidal volume, 6 to 8 ml per kilogram IW. Lung protective strategy to prevent volutrauma. PEEP, 5 to 10 cm H2O titrated. Keeps alveoli open and improves oxygenation while avoiding overdistension. FiO2, lowest to keep SpO₂ greater than or equal to 92%. Prevents hypoxia while minimizing oxygen toxicity. Plateau pressure, less than 30 cm H2O. Target to reduce risk of barotrauma and lung injury. Neurological monitoring, neurological assessment and ICP. 1. Glasgow Coma Scale (GCS-I), verbal and motor response, score 3 to 15. This provides a quick, standardized assessment of level of consciousness and brain function. 2. Pupillary size, equality, and reaction to light. This helps detect raised intracranial pressure, brain herniation, or brainstem dysfunction. 3. Sedation and agitation scoring, e.g., RASS, in ventilated patients. This ensures optimal sedation depth, avoiding both oversedation and undersedation. 4. Intracranial pressure (ICP) monitoring in traumatic brain injury. Normal 5 to 15 mmHg. Treat if sustained greater than 20 mm of mercury. This is because sustained high IC reduces brain perfusion and risks secondary brain injury. 5. Cerebral perfusion pressure (CPP) equals MAP. ICP. Target generally 60 to 70 mmHg. This target maintains adequate blood flow to the brain while avoiding hypotension or hypertension. Glasgow Coma Scale breakdown. Eye opening, 1 to 4. Reflects level of arousal. Verbal response, 1 to 5. Reflects orientation and language function. Motor response, 1 to 6. Reflects brainstem and motor pathway integrity. Rule: GCS less than or equal to 8 airway at risk, consider intubation. This is because a low GCS indicates inability to protect airway and high aspiration risk. Renal and fluid monitoring. Urine output and fluid balance. 1. Hourly urine output reflects renal perfusion and overall circulatory status. This is because kidney blood flow depends on cardiac output, so low output often means poor perfusion. 2. Target. At least 0.5 milliliters per kilogram per hour in adults. This threshold indicates adequate kidney function and sufficient circulatory volume. 3. Strict fluid intake and output charting, oral, IV, drains, and losses. This provides accurate fluid balance and helps guide fluid replacement decisions. 4. Daily weights help track cumulative fluid balance over days. This is useful as 1 kilogram weight gain roughly equals 1 liter of retained fluid, showing hidden overload. 5. Serum creatinine and urea monitor renal function. This shows how well kidneys are filtering waste and whether injury is progressing. 6. Oliguria less than 0.5 milliliters per kilogram per hour is an early warning sign of acute kidney injury. This signals reduced renal perfusion or early kidney injury needing prompt review. Urine output target. Greater than or equal to 0.5 milliliters per kilogram per hour. Below target for 2+ consecutive hours warrants prompt clinical review, as this may indicate deteriorating renal or circulatory status. Physiological monitoring. Temperature monitoring. 1. Core temperature is most reliable, measured via esophageal, bladder, or rectal probes. This gives the closest estimate of true body temperature as it measures internal organs. 2. Peripheral, axillary, tympanic sites are convenient but less accurate in shock. This is because poor peripheral perfusion in shock makes skin and surface readings unreliable. 3. Fever may signal infection or inflammatory response. Hypothermia predicts poor outcomes. This is because temperature changes reflect immune activation or failure of thermoregulation in critical illness. 4. Continuous monitoring is used in hemodynamically unstable or post-cardiac arrest patients. This allows early detection of temperature changes that can affect outcomes and management. 5. Targeted temperature management is used after cardiac arrest to protect the brain. This helps reduce brain injury by controlling metabolic demand after return of circulation. Normal core temperature. 36.5–37.5 degrees Celsius. Fever. Greater than or equal to 38.0 degrees Celsius suggests infection or inflammation requiring investigation. Hypothermia. Less than 36.0 degrees Celsius indicates heat loss or impaired thermoregulation and associated with worse prognosis. Sites of measurement. Esophageal, bladder, core. Most accurate for continuous monitoring. Rectal. Close to core but lags behind rapid changes. Tympanic. Quick but can be affected by technique. Axillary, least accurate. Convenient but least reliable, especially in unstable patients. Advanced monitoring. Hemodynamic and cardiac output monitoring. Advanced techniques quantify how much blood the heart is pumping and how the vessels are responding. This helps guide fluids, inotropes, and vasopressors in critically ill patients. Thermodilution (PAC). Invasive gold standard cardiac output via pulmonary artery catheter. This provides direct measurements but is invasive and reserved for complex cases where detailed data is needed. LIDCO. Less invasive continuous cardiac output from arterial waveform analysis. This gives beat-to-beat output with less risk than a pulmonary artery catheter. Echocardiography. Non-invasive bedside assessment of cardiac function and filling. This allows quick visual evaluation of contractility, filling status, and overall cardiac performance. Passive leg raise. Bedside test predicting fluid responsiveness without extra fluid. This temporarily shifts venous blood to the heart, mimicking a fluid bolus to see if cardiac output improves. Key parameters. Cardiac output (CO) 4 to 8 per minute. Indicates total blood pumped by the heart per minute and overall perfusion. Cardiac index C 2.5-4 L per minute per square meter. CO adjusted for body surface area, allowing comparison between patients. SVR 800, 1/209 S per centimeter 5. Reflects vascular tone and afterload faced by the left ventricle. Biochemical surveillance. Laboratory monitoring. Electrolytes. Na+, K+, Ca2+, Mg2+, arrhythmia and neuromuscular risk. This is because electrolyte imbalance affects cardiac excitability and muscle function, so abnormal levels can trigger arrhythmias or weakness. Blood glucose. Tight control reduces infection and complication risk. This is because hyperglycemia impairs immune function and wound healing, increasing risk of infection in critical illness. Lactate. Marker of tissue hypoperfusion, trend guides resuscitation. This is because rising lactate indicates anaerobic metabolism from poor tissue perfusion, so falling levels show resuscitation as improving perfusion. Full blood count. Detects anemia, infection, and thrombocytopenia. This provides information on oxygen carrying capacity, inflammatory response, and bleeding risk from low platelets. Coagulation profile. PTINR, APTT, bleeding and clotting risk. This helps assess clotting function and guide anticoagulant use, blood product replacement, and bleeding risk. Cultures. Blood, urine, sputum, identify sepsis source and organism. This allows targeted antibiotic therapy and helps locate the focus of infection. Standardized assessment. Severity scoring systems. Composite scores standardize severity assessment, predict mortality risk, and track a patient's trajectory over time. This provides an objective measure of illness severity and helps guide prognosis and escalation decisions. Apache E. Acute physiology, age, and chronic health, predicts ICU mortality risk. This is because it combines acute physiological derangement with age and comorbidities to estimate risk of death. SOFA. Sequential organ failure assessment, tracks organ dysfunction over time. This is useful as rising SOFA scores indicate worsening organ failure and poor response to treatment. GCS. Glasgow Coma Scale, level of consciousness, 3 to 15. This provides a quick standardized assessment of brain function and helps detect deterioration. News 2. National Early Warning Score, bedside deterioration, escalation trigger. This is because it aggregates vital signs to provide early warning of clinical deterioration needing urgent review. Clinical practice. The clinician's role in monitoring. Continuous vigilance. Regular, accurate observation and documentation of trends. This ensures changes over time are noticed rather than relying on single values, allowing early intervention. Early recognition. Prompt identification and reporting of abnormal findings. This is important because early detection of deterioration allows timely action and prevents complications. Equipment care. Correct calibration, zeroing, and infection control practice. This is because accurate readings depend on properly calibrated and sterile equipment, and poor care leads to false data and infection risk. Alarm management. Setting appropriate limits to avoid missed events or alarm fatigue. This ensures true emergencies are not ignored due to too many false alarms, while also preventing missed critical events. Patient safety. Positioning, comfort, and prevention of device-related harm. This reduces pressure injury, dislodgement, and discomfort from monitoring devices and lines. Communication. Clear handover and escalation within the care team. This ensures continuity of care and prompt team response when a patient's condition changes. Safety. Complications of invasive monitoring. Infection. Line sepsis, CLABSI from arterial or central venous catheters. This is because invasive lines breach skin barriers, allowing bacteria to enter the bloodstream and cause systemic infection. Bleeding and hematoma. At the insertion site, especially with coagulopathy. This occurs due to vessel injury during insertion, and risk is higher when clotting is impaired. Thrombosis. Vessel occlusion around the catheter. This is because the catheter irritates the vessel wall and slows blood flow, promoting clot formation. Distal ischemia. Arterial spasm or occlusion after arterial line placement. This happens when the artery supplying the limb is blocked or spasms, reducing blood flow beyond the insertion site. Pneumothorax. Risk during subclavian, internal jugular central line insertion. This is due to accidental puncture of the pleura while accessing central veins that lie close to the lung. Arrhythmias. During pulmonary artery catheter advancement through the heart. This occurs because the catheter tip irritates the cardiac conduction system as it passes through the right atrium and ventricle. Summary. Key takeaways. Monitoring blends clinical judgment with technology. Never rely on numbers alone. Choose the level of monitoring: clinical, non-invasive, invasive to match patient acuity. Trends over time matter more than any single isolated reading. Invasive monitoring offers precision but carries real risks. Weigh benefit against harm. Early recognition of deterioration, through vigilant monitoring, saves lives. Thank you for watching. If you like this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.